just run through basically trach cares, suctioning, and then what to do if you have a trach-associated emergency. So we'll start with, I think on your guys' handouts, I'm starting on page 3. I'm going to come back to suctioning. I always like to do my cares first, but typically before you start your trach cares, I usually like to suction first, typically just because as soon as you start messing with the trach, they're going to cough, and it just kind of lessens the amount that comes out of the trach then. But we'll double back to suctioning procedures, but we'll just talk about trach cares. So there's a few different components. So first of all, and that will be dictated hopefully by physician order how often, but we were just discussing minimum twice a day. In the hospital, we actually do it 3 times a day, so whatever your policy or whatever the physician orders. So first thing you're going to do is start with your inner cannula. Most of the time nowadays, everything is disposable. So most likely the patients you will get from the hospital will have a disposable inner cannula. So all it amounts to is that you have to just make sure that you have the right size and style that you've gotten from the DME company. So you have all those. Make sure you have several on hand at any one given time. And then basically wash hands, put clean gloves on. It's not a sterile procedure, it's just considered clean. So just make sure you have your clean gloves on. And then you're just going to remove the inner cannula that's in place, set that aside, open up your package, take your new one out. And sometimes you got to start a little bit of an angle, especially if they have kind of a big neck and stuff. You can't just go this way. So sometimes you got to start sideways and then kind of just rotate it back that way, and then it should just slide right in. There's always a little click or a little pop to lock it in, and you can give it a little tug just to make sure it clicks in tight. Okay, the inner cannula, I think the very first slide there describes the actual parts of the trach. So you have the flange, which holds it to the neck, keeps it from sliding in and out. The outer cannula is kind of that the one that stays in place. Typically, we will change the whole trach about every 3 months. But otherwise, you are just cleaning or changing the inner cannula. And the inner cannula's purpose is just to maintain the patency of that outer cannula, so that you have something you can take out, clean, put back, and you're maintaining that open airway. Okay. Some of them come cuffed, and some are uncuffed. Okay, so you could get patients that have either, depending on why they have the trach in the first place. So or I should start with cuff trachs. Cuff trachs have the little balloon on the end. When the balloon is inflated, it actually blocks the airway, and air can only go in and out through the trach. Okay, no air can go up through the upper airway. So generally those patients won't have any airflow through the nose or the mouth. So they aren't going to be able to talk or anything like that. Those patients that need to have their cuff and have it inflated are patients that are being mechanically ventilated, which doesn't sound like you'll have those at first anyway. On a ventilator, don't stay away from that. But anyway, but if you do have patients that are at high risk for aspirating or have known to be at high risk for aspiration, they will have a trach with a cuff on it that needs to be inflated most of the time, so that if they vomit, they don't aspirate those contents back down into the lungs. So all of the other trach patients usually get away with an uncuffed trach. So that is just that tube that's in the airway that's just maintaining that open airway. Airflow can go in and out through the trach and can go in and out through the upper airway as well. So most of them will have airflow up through the nose and the mouth and be able to vocalize some. We'll talk about speaking valves too, but so those are the two differences there. Care-wise, like I said, that inner cannula is there to maintain the patency of that outer cannula. So if something gets plugged in that inner cannula, you can just take it out, pop a new one in. You don't have to replace the whole trach. That's what the purpose of that is for. So that's pretty easy. Take it out, pop a new one in, done. Okay. Next part to taking care of your trach patients is actually taking care of the skin around and underneath the trach. So most of your patients will have a drain sponge, generally just the white pre-cut drain sponges. You don't want to use 4x4s that you cut, just because the 4x4s have the actual fibers, and when you cut them, the fibers can stick in the opening and cause issues. So you always want to use an actual drain sponge. Take that out, throw it in the garbage. If there's a lot of drainage, you can take a sterile 4x4 and then pour some sterile water on it, and then just kind of do a quick wipe, get kind of all that yucky gunk off of there. Otherwise, you're going to use sterile Q-tips. Okay, kind of up to you. Has anybody in here taken care of trach patients? A few of you? Okay, so you probably, if you've taken care of trach patients before, you kind of already have what works for you. And this part doesn't really matter. You can take as many Q-tips as you want. I usually take about 6 or 8 all at once in my hand. You'll take your sterile water. I don't know if you guys have little things like this of sterile water, or if you have bigger ones that you have to pour into a basin, that's fine. But just gonna get them all wet. I get them all wet at the same time, and then just then come over to my patient. Kind of divide it into 4s is what works best for me. So I usually will start, and you always start at the stoma, and then kind of always either roll or swipe away from the stoma. And then that one's dirty. Take my other one. I do this one. Get up underneath there. Do this way till it's clean. Then I have my other 2. I do the bottom half, do the top half, and then my other 2 that I have. Then don't forget the trach itself. Okay, sometimes that gets little crusties in there, and so that is a good place for bacteria to grow. So you always want to clean the trach itself once you're done cleaning the skin. So don't forget the back side of the trach back here and the front side. Okay. Now typically you want to use just sterile water to clean the area. The only time you should use hydrogen peroxide is if you've got dried on crusty mucus that has dried onto the skin, or the trach itself, and it's really hard to get off. Then you can mix a 50-50 solution of sterile water and hydrogen peroxide together, and then dip your Q-tips in there, and then the hydrogen peroxide just helps debride that away from the skin and makes it easier to clear it away. Otherwise, sterile water is appropriate by itself. Okay, just let it air dry. Make sure you're really inspecting underneath that trach flange for any skin breakdown, increase in redness, anything that looks like an infection or skin breakdown. That's a super easy area for skin breakdown to happen. So if that occurs, then you just need to have someone come and take a look at it. Sometimes it's just ointment or a different barrier that we need to put in place. But once you've done that and it's all dry, you have extra drain sponges. Usually there's 2 to a package. You shouldn't need to use both unless they're really oozing a bunch of stuff out of there. Just take one, use the next one next time. This is always the hardest part. I always just get up underneath the trach tie and pull it up there, and then just kind of pull it this way, then back up underneath this tie, and then just kind of shimmy it into place. Second, how's everybody? Any questions so far? Trach change, trach cleaning. Okay, pretty straightforward. Trach ties. Again, typically, again, this would be whatever's ordered or however you guys want to do this. In the hospital, we're changing trach ties daily. So once a day, the whole tie should be changed. Simply because if they do have a lot of secretions that have been kind of oozing, that trach tie gets really wet. Other places I've been change it once a week, so you'll have to kind of figure out what works for you. But definitely along with your trach cares, you always want to make sure you're doing an assessment of the back of the neck underneath this trach tie, because this foam just absorbs moisture and it just kind of wicks back there, and then before you know it, now you've got a big open sore in the back of the neck from that. The other thing you have to watch for is if you don't change them daily, over time, especially with patients with larger, more folds in the neck, sometimes what happens is over time they kind of get stretched thin and then they start to roll up back here, and then it's just like having a shoestring tied around there really tight and can cause skin irritation and breakdown. So always watch the back of the neck and know what this tie looks like. Should be inspecting that every day. Okay. To change it, you can do that a couple different ways. It really depends on your comfort level. Okay. If you feel comfortable doing it on your own, that's certainly acceptable. Generally, there's enough room. So here's my new trach tie. I can come in. Generally, they're laying, you know, when you're coming at them from the front, but just for viewing purposes. But I have a tendency I like to put the new one on first, and there's usually enough room in there to get both trach ties on, and then all you have to do is take the old one off. If you need to get behind the neck and inspect that, or if he's got skin breakdown, then you definitely need a second person because you're going to have to remove the whole thing. Someone's going to have to hold that in so that if he does cough, it doesn't come flying out. And then that way then you can take care of the skin behind the neck and then put the new trach tie on. For tightness, for the trach tie, you should be able to get and maintain one finger underneath there. Okay? That's as tight as it needs to be. That usually keeps it from wiggling too much in place. The other thing to keep in mind too is that if you don't change it every day, again, after a couple days it starts to stretch a little bit, and so it may become looser. So always just kind of check the tension on your trach tie to make sure it just maintains that one finger. It doesn't become any looser than that. If it does, then when he coughs, it could come out. So, okay. Questions so far? Okay. I'll double back to suctioning. Okay. So suctioning again is a procedure that should only be done as needed. So there's no reason to suction your patients on a regular basis, like every 4 hours or every 2 hours. That's not needed. Listen to breath sounds. If they sound junky, you can just hear stuff kind of rattling around down in there, then generally you want to get your suction out and suction. Even if the patients have a fairly strong cough, usually the coughing, they don't cough everything out. There's always a little bit that gets stuck inside the trach tube. So even just some shallow suction just to clear that tube out is always good afterwards. So sterile suctioning. So what you need for suction is your suction machine, your sterile suction kits, sterile water. So you open up your kits. Your kits probably look different than mine. Mine are from the hospital, but I put my sterile gloves on, assuming nobody has a problem putting sterile gloves on, right? You guys do that probably more than I do. So sterile gloves, right? And then now both hands are sterile, remember. So I'm going to pretend I've got my sterile gloves on. So I can pick up the catheter that's in there. I can grab it with both hands. Okay, doesn't matter what you do with it. Both hands are sterile. I usually just pick it right up out of the package. But now, then you got to grab the suction hose from your suction machine. So you have to, before you do that, you have to pick which hand is going to be your dirty hand. Okay, so usually your sterile hand, if you have a hard time choosing, most people feel most comfortable with their dominant hand being their sterile hand. So pick up your suction, put that together, and then your dirty hand can touch this part of the suction, and then the rest is sterile. Okay? No need to use drops or anything like that. Just set your suction pressure, which we'll talk about in a moment, and then just tell them, I'm gonna make you cough. Just nice and easy until the patient either coughs or you meet resistance, whichever comes first. Put suction on, hold it continuously, and then nice and easy come back out. You can rotate if you want to, doesn't matter. Just comes all the way back out. Watch the tip of the catheter as it comes back out so it doesn't fling and hit anything. And then you can hold it in your sterile hand again, and then you have your dirty hand to put your oxygen back on or whatever. Okay. Suction pressure, generally 80 to 120 millimeters of mercury pressure. Okay, does that sound familiar to everybody? Any less than that, Generally for your adult patients, anything less, you're probably not gonna have enough suction. Anything higher than 120 really is too high. So remember, suction is vacuum. You're actually sucking oxygen and volume out of the airways. And as long as you stick to that no higher than 120 and stick to your time constraints, generally, as soon as they take a breath, when you're done suctioning, those alveoli pop back open and oxygen levels pop back up. Does anybody remember what the time limit should be? Yeah. Generally 5 to 10 seconds should be your limit. And I certainly, like I tell everybody, I don't expect somebody to like watch the clock, but I know a lot of RTs, a lot of nurses that I talk to, they'll hold their breath. So like they'll hold their breath and then they go down and suction, and about the time you're a little uncomfortable, you can guarantee your patient is too. Or just go down, come right back out again. I tell people, even if you are sucking up a ton of stuff down there, don't sit down there. Just come right back out again, let them recover, and you can go down as many times as you need to. If you need to go down 10 times to get them cleared out, go down 10 times. As long as they tolerate the procedure all right, there's no cap on the amount of times, just limit the amount of time, okay? The reason we say only go until they cough is generally most patients will cough as soon as this tube comes out the trach. As soon as it gets to about right there, it usually triggers their cough response, and that's generally where they start to cough. If they don't cough, generally we say till you meet resistance. Well, the resistance you meet is generally the bifurcation of the airway into right and left main stem, and then you're actually hitting the tissue where it divides. And so over and over and over again with aggressive suctioning can actually cause scarring and tissue breakdown. So you just want to be nice and gentle. Continuous suction. I know some of you have probably been taught intermittent. We don't encourage that, simply just because if I go down and I'm suctioning back out again and I let go, and let's say I had a great big mucus plug on the end of my suction, what happens to it?
Stops right there on the wall.
Stops right there in the airway, right? And now you have an obstruction, so possibly. So that's generally why we say just keep your finger on the suction and then just keep coming right back out. Yep.
As RT, how long do you typically let them recover between the I know
Each-
you mentioned a one breath deal, but
Yep.
10,
Oh, a little bit longer, yeah. Usually it takes one breath to kind of reinflate all those alveoli that have maybe collapsed with the vacuum pressure. But typically, I give them about 30 seconds. And again, it depends on the patient. If he coughs and coughs and coughs and coughs and coughs, he might need, maybe a minute or two to kind of recover, catch his breath again, let those oxygen saturations come back up. So it's kind of patient to patient, but from what I've usually seen, most of your stable patients go down. I usually give them about 30 seconds, and usually they're ready to go again. And you can ask your patient too, are you ready? You need a little bit more time, if they're able to respond to you. So, did that answer it? Yep. Okay, good. Okay. Any other questions with suction? Now, with suctioning, I don't think it's on your sheet, but later on we talk about mucus plugs. It is very, very important to monitor the consistency of the secretions, okay? Normal secretion should be small amount of clear white sputum, okay? But sometimes when your trach patients are introduced into an environment that doesn't have enough humidity, the response of the airways is that everything becomes thicker because it starts to dry out. And then things don't move up the way they should. And so we tend to retain secretions, and those secretions become thick and sticky. So if you've noticed a change in those secretions, they used to be really thin, small amount, now we're in the winter months and it's drier, and now you have your patient, you're suctioning out maybe more moderate, thicker secretions. We really need to monitor the amount of humidity, so they might need increased humidity. How we give humidity to the trach patients. Most of your trach patients are probably wearing what's called an HME. Okay, we have different ones out there. This one has an adapter so we can deliver oxygen at the same time with it, but some of them are just, they look like a little tube. But what happens is they have little corrugated paper in there, which works a lot like a nose, so like your nose. So what it does is when the patient exhales through here, it captures all the heat and humidity, and then when they breathe back through there, it releases that heat and humidity. I kind of describe it as when we're outside in a 30 below day and you're wearing your scarf. Okay, you got your scarf over your face, right? And you notice when you breathe through the scarf, all of a sudden you get that condensation on the scarf. The HME in your nose works the exact same way. The scarf is hanging on to your heat and your humidity. That's where you get that little frosty. And then as you breathe back in through your scarf, you notice it's not as cold because it releases that heat and humidity back to you as you breathe back through. HME works the exact same way. So it's meant to humidify the gas that your trach patients are breathing in. So, and the HMEs just go right over the trach. Now the downfall of this is, tell me what you think is going to happen if this patient now has really thick, large amounts of secretions that they're coughing up. It's going to include your HME. Right, exactly. So again, we need to kind of keep an eye on those secretions ahead of time, and then know when it's not appropriate to wear this anymore. So if they're coughing stuff up and you notice they're getting gunk that's getting in there, it's appropriate to take it off at that time. And then what needs to happen is we probably need to get a hold of the physician so they can write an order for increased humidity, and that usually comes from the DME company. They're the aerosol delivery devices. They're a little bit more cumbersome. Usually have to hook them up to an oxygen concentrator if you don't have piped in oxygen concentrator, but it blows like a mist. It's basically a small humidifier that blows right at their airway then, and then they inhale the particulate water and it thins those secretions down, makes them more manageable. Okay? All right. I'm going to pass around my trachs here so you guys can kind of play with these a little bit. So I brought, here's the non-disposable. They're two different kinds. So this is the older style of Shiley trach. So we're trying to get away from these to the new flex trachs. So I'm not sure I would assume most of the patients will come with these new flex trachs because they're going to stop carrying these. So it'll either be, this one is cuffed or they'll come uncuffed, but I'll pass around. To deflate and inflate the cuff, you just use a syringe, and then there's a spring-loaded valve here. Just pop that on there, push air in, deflate, inflate. You can kind of play with that. And then if they need to, the HME can be hooked to oxygen too. So depending on what the oxygen needs of your patients are. And I'll pass this around too so you can see the HME and what it looks like on the inside. Speaking valve, has any of you worked with the passing mirror? Anybody else? No, pretty new. And again, I'm not sure about some of the patients that we have that might be using this, they might not. If they have a cuffed trach and we are leaving the cuff inflated, this is a no-no, okay? But if they have an uncuffed trach, they may come with a passing mirror valve. The passing mirror valve is a speaking valve. It's a one-way valve, so it allows air to go in but not back out, okay? So if I put that on there and if air can't go back out there, where's it gotta go? Up through his upper airway, right? So that's why if you have a cuffed trach, that doesn't work, right? Because if you have a cuffed trach and you try putting that on, what's going to happen? Lots of bad things. There's no airflow. He can't get air up through his, so he can keep sucking in, but he can't exhale. And so either it's going to pop off, and that's if you're lucky. If not, cardiac arrest. So And even, you have to be careful, even if your patient doesn't have a cuffed trach, okay? It varies as the amount of airflow that can sneak past that trach up through the upper airway. If he has a big trach and a small airway, we have some inflammation going on in the airway, and we can't, get enough airflow. We're going to have more issues. So anytime you put that on, you always want to do an evaluation. So they should never wear it at night. Okay, they shouldn't be talking at night anyway, so it should be open and getting humidity. Otherwise, during the day, if you're going to place that on, let's say you're going in the morning, you're going to place that on there. After you place it, have them talk to you. That's the whole purpose of it. They should be able to voice comfortably. It shouldn't be any added resistance with the device, even though it's a one-way valve. Generally, we don't find any additional work of breathing. So if you do find additional work of breathing, take it right back off again, and then reevaluate at a later time. Maybe they're getting an infection, they've got some swelling. Just kind of double check. Okay. These also do have an oxygen adapter as well that snaps on them. So again, depending on what the oxygen needs of your patient are, we can attach that oxygen tubing, and then it just blows right in front of the device here, and then they just breathe that in and out, just like they would kind of a cannula device. Okay. One other thing with the HME that I forgot to mention as I was talking about increased work of breathing, the one thing you have to watch out for with that filtering, the paper, is that after a significant amount of time, depending on how often you change that, if that paper gets really, really wet, it can increase work of breathing. So again, if you notice increased work of breathing, your patient has that HME on, double check to make sure that, one, it's not occluded, and two, that it's been changed recently. So we usually once a day, but again, it just depends on your process. Okay. Questions up to this far? Everybody feels good? Jump right in there and okay. And I'll go back through, make sure I didn't miss anything. Like I said, I kind of jump around a little bit. Emergencies. Okay, what happens if, like I said, it's all fine and good as long as everything stays in place and works well, right? But what happens when things don't work very well? So number one, let's just say you went to go change the trach ties and missed the loop or something like that, and he coughed really hard and whoop, it fell right out. What are we going to do? First, just assess, okay? Most of your patients that you guys are going to get here in the nursing home or skilled facility, they should be stable, okay? So if they lose that trach, they've had it for a while. They're going to cough it out. It's not like that bowl's going to close right up, okay? It takes a few days, okay? So they have a fairly well-established airway tract and that they can still breathe through. So they just don't have the tube there, but they can still breathe through that opening. So I would say 99% of the time when that happens, they're just going to look at you like, oops, okay? Just assess that patient. Make sure they're breathing comfortably, no respiratory distress, okay? And if that happens, then it depends on your comfort level here as to what to do next. So generally speaking, all of your trach patients, though, should always have an extra trach bedside of the same trach that they currently have in. You want to always have an extra one in case something like this happens. If it does, then what you want to do is, if you're comfortable, you can just put the trach back in again, okay? You can put the same trach back in again as long as it doesn't hit anything and now it's dirty. If it just kind of fell out and it's just kind of sitting right here, you can put that one back in. If it hit the floor, then you want to grab the new one out of the box, okay? Now, what do? Every trach should come with what's called an obturator, okay? This is just it's a solid tube. And if you don't have the one that's currently for the current trach that they have in, typically we suggest that you tape it to the head of the bed, like on the wall, so it's visible to everybody. If you don't have that, then you'll need to grab the new trach out of the box. When you take the new trach out of the box, it's generally the trach and the obturator. You have to take out the inner cannula, okay? Otherwise it won't fit in there. And then you put your obturator in. What the obturator does is it rounds out the bottom of the trach. So if I tried to just put this fell out, I was going to put it back in. This opening here has a tendency to gouge on the back of the tracheal wall, and you can cause damage. So by putting the obturator in, you basically filled in that opening. And now if I put it in, it just glides right down, causing no damage. So basically, again, you can have them, you're going to have them probably laid down flat and get the neck back a little bit. And then when you go in, you're probably going to have to go sideways and then straighten it out. So you'll have to kind of come in this way and then kind of angle it that way. Generally, before you slip it in, you want to put lots of KY on there. Okay? Makes it slide in easier. Once you get it in, take that out because you can't breathe through it. Okay? Put your inner cannula in that was in the box and feel. What should I feel here? You should feel airflow, right? If I got it in the right spot, you should feel airflow. Unfortunately, there is a false channel that lays right in front of the trachea that sometimes it likes to go into, so if you don't feel any airflow, you probably just got it in that false channel. Take it out, start all over again, try it again, okay? But as long as you feel airflow here, you can pretty much be sure that you've got it in the tracheal airway, and then you can put your trach ties on and get it back into place, okay? That's if you're comfortable. If you're not, you have to call EMS, and then they'll transport them to Sanford or wherever, and then we put the trach back in the ER. No big deal. So it just depends on your comfort level with that. Okay? Now let's go opposite though. So it fell off, right? And now he is really struggling to breathe. So kind of the opposite. He's not okay. What are we going to do? First of all, we're going to call EMS, right? Okay? And then second, we need to breathe for the patient, right? Okay, so all of your trach patients, again, should have bag mask valve, right? Okay? I'm going to bag this patient. Anybody?
What'd you say?
How am I going to bag this patient? Any guesses?
Well, you have to cover that hole.
I got to cover the hole, right? And then what?
It would do it over the smoke.
Yep. You got it. Because if I don't cover the hole, what's going to happen?
Right.
It comes out the hole. And you know, it's funny, but I've seen it happen, you know, and then you realize it as soon as, because the air is just going to blow right out.
Right.
Now, and either one is the airway. So you have to cover one. And honestly, it's easier to cover this than it is to try to do this.
Yeah, I bet.
They're both options. They're both an option, but you can't really do that. So, and a lot of times it's hard to get a seal on the neck too. So it's just easier to bag and then have somebody. You can take a sterile 4x4 and then try to hold that. Again, you're probably going to get, as soon as somebody gives a breath, you're probably going to get some leakage through here. The trick is going to be to try to minimize the leakage through the tracheal airway hole there, and still get good chest rise. So it would be just like bagging any other patient at that point. Someone's got to hold this nice and tight, mask bag, and then still give good enough volume to get good chest rise. If you're not getting chest rise, there's still something wrong. Then we're not getting air into the lungs. Make sure you're opening that airway all the way. Back to that BLS, right? Open the airway, and then make sure your mask is tight. Make sure the tongue isn't falling in the back of the throat. All those kinds of things. And then make sure you have a tight seal. Okay? Okay, let's go this scenario. I'm going to stick that back in there. We'll say it's strapped in. Okay? Okay, so now you go in to check on your patient. Now, some of the patients come, they have sat monitoring, some of them don't. I guess it just depends on what they send them with. We'll just say you go into the room to check on the patient, and he looks very distressed, okay? He's really working hard. He has kind of a dusky color, and you feel not much airflow coming out of the trach. You listen, not much air movement through the lungs. What are you going to do to troubleshoot? What are you thinking is going on?
Start with the filter on the end.
If he had his HME, yep, you'd take that off and look. Okay, it looked fine.
Replace the inner cannula.
Okay, because what are you thinking is going on? Plug, right?
Mhm.
So there's an obstruction most likely of some sort because we're not getting airflow. So you're right, take off the HME if that was on there. Second, fastest thing you can do is look at the inner cannula. I can pop that out in a second, look at it, ooh, that was all really yucky. And then now I opened that up. Ooh, you can get a breath. I'm gonna put a new one in. You're good to go, okay? Because unfortunately when they cough, it's nice that they are strong enough to cough stuff up there, and then they usually like to use a tissue and cough stuff up. The problem is that there's always a little bit of residual that sits in the trach, and then it dries in there, and then they cough some more, and that dries in there, and before you know it, they're breathing through the size of a pinhole instead of the size of a straw. Okay, so that's why you kind of have to watch those secretions. Good. So we'll say I pulled this, and it looks fine, nothing's wrong with it. Okay. Third thing, or second, whichever, suction. Okay. Usually I say suction, not first, just because it's going to take you, a minute to put your gloves on, grab the suction, turn it on, and get down there and see if you can suck anything. Because sometimes they have problems. Some of those mucus plugs get stuck on the end, and then it flaps over the end, and it gets stuck. And sometimes you can grab that with suction. Okay. 1, 2, 3 didn't work. Okay, so we tried, the HME looked good, the inner cannula looks good, I tried suction, I got nothing. Last thing, we just tell you, you can try repositioning it if it looks like it was hanging halfway out maybe the end of it just butted up against the back of the airway wall. You can try readjusting the trach or the patient's, head a little bit to see if we can get airflow through there. If that doesn't work, just pull it, okay? It's not a working airway anyway. It's not working, you're not getting airflow in and out, just get rid of it, okay? After that, about, I would say 95% of the time, once you pull that, patient will start breathing through that open stoma, okay? If not, go back to our breathing then, same thing. If he doesn't come around still in lots of distress, or still don't have much airflow, cover, mask bag, okay? Everybody comfortable with that? More or less. And the one thing to remember is that your patients here are going to be fairly stable. So if they do lose it, like I said, most of them are just going to breathe through that open stoma. Blockages, usually blockage happens from mucus plugs. Mucus plugs form when we don't have enough humidity. So when I was talking about secretions becoming thick, along with becoming thick, they also start forming what's called mucus plugs. I don't know if anybody has gotten the chance. Has anybody gotten to see mucus plugs? A couple of you. I relate them to a child who has picked their nose, and they got the big thick booger on there. Okay, that's what they look like. They are big, thick plugs of thick mucus that a lot of times won't even go up your suction catheter. They're thick, and once they start forming plugs like that, you know for sure you don't have enough humidity. And then if they cough, that's what generally can get lodged somewhere in that trach tube and cause an immediate obstruction. Okay. Also watch just for, in general, increased work of breathing, especially if they're coughing stuff up. Just a generalized increased work of breathing, like you said, just check that HME or change the inner cannula, because they probably have a bunch of stuff that's built up in there that's reduced the breathing diameter. So let's see, let me make sure I covered everything. Okay, indication, And I don't know, do you guys have humidifiers that you put in the patient's rooms at all, or no? No? Okay, so more like the hospital in that sense then, okay.
So they do use the through the whole system.
Through the whole system? Okay.
Yeah.
That's kind of nice, that is very nice. I know we have problems in the hospital, and then of course they took away the use of humidifiers. And so now, again, so you guys would kind of be in the same boat in that if you had humidity issues with your trach patients, again, it would have to be a physician order for a different oxygen device that would provide more humidity. And those come straight from the DME company, they would come in and set them up. And they've got non-heated and heated options. The one thing I'll just cover, although I don't think you guys would see them, but if you ever were to get a laryngectomy patient, those are different. So laryngectomy patients are different than trach patients in how you would resuscitate for the most part. Everything else is the same. Laryngectomy patients, they don't have a communicating upper airway because it's been severed. And so their airway actually starts here. So if you were to do any rescue breathing, it would have to be at the stoma. So no mass bagging for those patients. That's all I'm going to say about that because we just do trach patients. I feel like I talked kind of fast. Does everybody feel pretty good with what I talked about? You guys feel pretty good about taking a patient and doing trach cares and trach changes? I didn't really touch on that, but those generally are not done here. For the most part, they would either make an appointment for the patient with their ENT and do it in the ENT's office, or a lot of these patients come in through through Sanford's ER, and one of our RTs changes them out. So they would just, EMS would, or your transport, I don't even think you have to call it EMS, it would just be your transport for them, would bring them to Sanford's ER whenever that would be scheduled. And then, so it's just a scheduled procedure, but through our emergency room. It's weird. It's kind of weird. It's because it's a bed and they're not really a patient. It has to do with, and then one of our respiratory therapists changes it. So it's in a more controlled situation. We change them out and send them on back. So usually it's pretty smooth. We just take the whole thing out, pop the whole one thing back in. Usually it's about every 3 months. Otherwise, anything longer than that, typically they have a tendency to kind of break down. But the ENTs usually suggest about every 3 months. And that would be an order that they would write as well. I'm trying to think. Do you guys feel like you need practice suctioning or anything? Or do you guys feel pretty good? Feel pretty good with that? Okay. That's all I have. Unless you guys have any other questions for me.